Hello and welcome to the first class for the Advanced AEMT refresher. This first one is called Airway Management. It's a airway management for the Advanced EMT. Not a ton different than what EMT basics can do here in Wisconsin, but here it is, a little bit extra. Little anatomy and physiology review. So the airway is broken up into both the upper and lower airways. The upper airway involves the nasopharynx, the oropharynx, all the way down to the larynx. So the function of that upper airway is to humidify, filter, and moisten. So to humidify, warm, and moisten that air as it comes into your lungs, right? So down here by the larynx and the back of the pharynx, you have your epiglottis. The epiglottis is there so that food doesn't get into your larynx and trachea. Then down below, we have your trachea on the lower airway that comes down to the carina, which splits off into your right and left main stem bronchi. And then from there, we go down to the bronchioles and to the alveoli, which kind of look like these little sac-like things down here, right? At which point in these alveoli is where we have gas exchange going on. There's lots of blood vessels attached to them. So lower airway is there to facilitate gas exchange. Get air into the lungs, divides in, and we just talked about this, divide into the carina, two main stems. The right side is a little bit straighter than the left side. So you might hear, if you're working with a paramedic, that someone right main stemmed a patient, and that would be if they sent the tubes too far down into the airway. Yeah. And then the lungs, down to millions of little balloon-like sacs that are called alveoli, right? And that's where the gas exchange is happening. There is surfactant within the alveoli, and that is there kind of a lubricant, but it's also there to prevent the atelectasis or the alveoli from collapsing on themselves. So the respiratory and the cardiovascular system have to work together in order to maintain oxygen nutrients out to the body. They work hand in hand. If one fails, the other one is not going to be as effective and might get some cellular death happening as a result. Not only are they moving oxygen nutrients, but they're also getting rid of some waste and getting that out of the body, like your carbon dioxide. So your active breathing is broken up into three separate aspects, right? We call it ventilation, oxygenation, and respiration. All are necessary for life, and we got to make sure that we maintain that. So ventilation, right? That's that physical act of moving air in and out of the lungs. So that's just the moving of the air in and out. Broken down into two, inhalation and exhalation. Oxygenation is the physical loading of oxygen molecules onto the hemoglobin, right? So each oxygen or each hemoglobin can carry 4 oxygen molecules. So that's what we're trying to do in oxygenation. Respiration, that's the gas exchange going on. And that can be broken down into internal and external respiration. So inhalation, part of ventilation, right? This is an active process, takes energy. Muscles are going to contract. So we've got our diaphragm contracting and our intercostal muscles between the ribs and around the clavicles. Those are all going to contract to expand the lungs, right? Make the lungs bigger. And by doing that, what's going to happen is that we're going to pull air into the patient's lungs, right? Negative pressure, pulling that air in. Tidal volume is the amount or that depth of breathing, right? So how much air is getting into the body. Dead space is that portion of the volume that doesn't reach the alveoli. Okay? And then that alveolar air is the portion that gets to the alveoli. And that's really all that gas exchange happens. And so the dead space, no gas exchange happening there. And that's from the bronchioles all the way up to the mouth and nose. Right? Exhalation, passive process, the muscles relax, right? And it starts with that Herrenbauer reflex, which maximum kind of inhalation, you get that reflex and we just exhale, right? Everything relaxes and we push that wasted air out and then do it all over again. So for regulation of that ventilating, the body does that by measuring your pH levels within your body, primarily the central CSF, your spinal fluid. So we're looking at how much carbon dioxide is really in there, right? So if there's too much or too low of a pH, we're too acidic, right? We're gonna breathe a little bit faster to try to get rid of some of that stuff, right? So we're gonna try to fix that. The body will look at that to fix, right? So oxygenation, that's the process of loading molecules, like I said before, needs to happen for internal respiration to take place. So if we don't get oxygen onto the bloodstream within the lungs, they're not going to get oxygen out to the cells. So required, needs to happen. And you can get ventilation without adequate oxygenation. So that's where your patient's breathing okay, but they're still potentially turning blue, or in the case of CO, maybe turning red, right? So they're breathing at an okay rate. They're just not getting the oxygen onto the bloodstream and the hemoglobin. So we're having issues with getting respiration happening. Usually happens in miners or climbers where there's low ambient oxygen in the area. Respiration, right? Again, like I said, there's internal and external respiration. This happens by diffusion. And what I mean by that is you're getting, when you take a breath in, we've got higher amount of oxygen in our lungs, less in the bloodstream. So oxygen is just going to passively cross that membrane and go into the bloodstream. And at the same location, there's higher amounts of carbon dioxide in the bloodstream than in the lungs. So you're going to get that passive moving of the carbon dioxide to the lungs. Okay? So higher exchange to lower exchange. A higher concentration to a lower concentration is where they're going to move. Okay? And that's happening in the lungs. That's called external respiration. Okay? Internal respiration is happening down at the cellular level. So out at the capillaries, right? We're getting oxygen, carbon dioxide moving from the cells of the body into the bloodstream and vice versa. So again, it happens by diffusion, right? So higher concentration, lower concentration at the cellular level. There's more oxygen in the bloodstream than in the cells, so it crosses over there. And then there's more carbon dioxide in cells, crosses back to the bloodstream. Okay? And this is generally done with aerobic metabolism, meaning there's adequate oxygen for this to happen. The cells need energy. Okay? If there's adequate oxygen, this happens relatively easy. Without adequate oxygen, the cells still need energy, so they end up using a process called anaerobic metabolism, which is going to use more energy and produce less energy in the process. So if no oxygen is there, or not enough oxygen is there, we start getting byproducts of that anaerobic metabolism. Okay? Probably experienced this when if you've exercised a little bit too hard and you start getting muscles, tightness, cramping, pain in the muscles, like we call it lactic acid, right? So that's kind of that byproduct of anaerobic metabolism. So the muscles were being used more than what the oxygen levels were available to use them. So it's created lactic acid, right? It causes pain sometimes. Yeah. Again, respiration passes through the capillaries to the tissues, right? Carbon dioxide goes the other way. Yeah. And then in the lungs, we get rid of that wasted carbon dioxide by breathing. Again, brain's going to control this. We don't have to think about it. It looks at lots of different things, primarily the pH levels, to make sure that we're getting adequate oxygen and nutrients out to the body, right? So things that can affect your respiration, obviously an obstruction. If there's an airway obstruction, we're not going to be able to move air. Okay? Different medications that depress your central nervous system, i.e. fentanyl, morphine, Versed, any of those things that kind of depress your mental status could affect your breathing. Okay? Trauma to the head and spinal cord. Okay? If we get some trauma, especially to the brainstem area, that might cause an issue with breathing appropriately. Okay? Medical conditions, i.e. like a stroke or seizure, something like that might cause, especially if it happens in that breathing in the medulla area of the brainstem, we might not be breathing appropriately either. Other medical conditions, different things could be like diabetes, right? We start affecting our pH levels in our body, it's going to affect how the patient is going to be breathing. Trauma to the airway and the chest also, right? If there's any trauma to those airways, we're not going to be able to move air appropriately. Then we look at the respiration, right? Things that generally affect respiration is the amount of oxygen getting into the system, right? On the external respiration side, if we're not getting adequate air ventilation coming in, right, there's not going to be enough oxygen getting to the lungs for respiration to happen. And then same thing with different things like COPD, for instance. If we're reducing that area in our lungs for gas exchange to happen, there's not going to be breathing appropriately. Okay. So internal wise, if we don't have enough surface area for gas exchange to happen, we're not getting oxygen out to the system either. So that's all going to affect our breathing. If we have issues with the heart, right, we get circulatory compromise with the heart. Obviously, we're going to have issues with moving blood and getting oxygen out to the system. So trauma could cause it, blood loss, a little anemia, might cause it shock, right, low volume, or we end up with vasodilatory shock, where the vessels are getting bigger. Okay. So when we're looking at that pH level, right, this is a lot of what's controlling how well we're breathing. So the respiratory system and the renal system are working to maintain that pH, right? Maintain an acid-base balance. And this makes sure that we stay in a homeostasis. So our body is staying relatively the same at all times. Lots of things that we can do for our patients will affect that, okay? i.e. using the BVM, right? If we're going to be breathing for our patient, it's going to affect the acid-base balance of our patients. Hopefully we can use the BBM to correct it, but that is one of those things that we can do. Otherwise, other things like giving fluids to our patient can affect the pH levels in our patients also. So if we increase the amount of hydrogen ions in the system, we're causing acidosis, right? If we're decreasing the hydrogen ions, we're becoming more basic or alkalotic. And our body has a whole system of buffers that's going to maintain that, okay? Or help maintain that at a general location, right? That we want to maintain a pH level between 7.35 and 7.45. Okay? So those buffer system will help maintain that. And that three components are circulating bicarbonate, right? So if there's some bicarbonate within the bloodstream, right, that can connect with the hydrogen ions and make water and carbon dioxide, right? So by breathing, doing the respiratory component, breathing off some of that carbon dioxide, we're reducing the amount of carbon dioxide in the system, therefore getting rid of some of those hydrogen ions. So those two components do work together, right, to help reduce the acid. And then your renal component, right? If you're going to urinate off some excess acid through your renal system. Okay. So if the fluctuation pH is due to the amount of bicarbonate in the system, we call that metabolic, right? So if it's a chemical reason that this person is acidic or alkalytic, right, we call it metabolic acidosis or alkalosis. If it's fluctuations due to some sort of respiratory disorder or respiratory distress or whatever might be causing you to not breathe appropriately, that could be respiratory acidosis or alkalosis. Okay. The problem is in the field, it's really hard to tell the difference sometimes. Okay. So respiratory acidosis is always related to hypoventilation. So if you're not breathing fast enough, okay, you're going to become acidotic. Okay? So we can fix that by breathing a little faster with the BVM. Okay? So some of those causes could be your airway obstruction, cardiac arrest, an overdose of some sort of CNS depressant like fentanyl, morphine, something like that, submersion, head trauma, or chest trauma. Okay? Something that's affecting you breathing fast enough. Signs and symptoms. Okay? You could get vasodilation, headaches, red flushed skin, altered mental statuses, slow breathing, nausea, vomiting, or hypercalcemia you might see during these. Okay. Again, some of these are hard to see in the field, right? Nausea, vomiting, slow breathing, altered mental status, skin changes, right? Those are things you might see. Blood pressure differences, maybe. So that's all potential acidosis, right? Alkalosis, respiratory alkalosis, is from hyperventilation. So if they're breathing too fast, okay, we're going to become basic, right? So breathing too fast, you're going to see things like certain drug overdoses like aspirin or uppers might cause you to breathe a little fast. Fevers maybe, or your potential that us as the responders are breathing too fast with the BVM. Okay. We have ways, now it's kind of become the standard. We monitor our end-tidal CO2, and I'll talk about that in a little bit, but that can help us maintain a good BVM usage. So, signs and symptoms of respiratory alkalosis: decreased cerebral perfusion, decreased mental status, right? So again, mental status changes. You're going to see that with acidosis also. Lightheadedness, maybe some hand and feet spasms, tingling on the lips, chest tightness, confusion, vertigo, blurred vision, nausea, vomiting. Right? Those are all things that we might see here also if they're acid or alkalotic. Okay? Metabolic acidosis, on the other hand, is something not related to any acidosis not related to the respiratory system. Okay? This could be your lactic acidosis. Okay? Could be caused by not enough oxygen internal respiration happening. Might be that cause. Ketoacidosis, like in your hyperglycemia, aspirin, too much alcohol, or lots of nausea and vomiting could potentially cause this. Okay. Again, vasodilation, mental status changes, headaches, flushed skin, hypercalcemia, fast breathing, nausea, vomiting, and dysrhythmias. Okay. So if you look at this compared to the respiratory acidosis, not a ton are different. The way you're going to be able to see that is if your end tidal is high, because again, it's generally hypoventilation. So if they're not breathing fast enough, we're maintaining CO2. So if they're breathing too slow, right, our end tidal is high, it's probably respiratory acidosis. If they're breathing too fast, right, it could be metabolic acidosis. Again, very hard to tell the difference in the field. Fix the breathing, maybe we fix the acidosis. Again, maybe. Metabolic alkalosis, we get too much loss of acid from a non-respiratory reason. This could be urinating too much, or just nausea, vomiting, excessive water intake, and excessive antacids intake. So they take too many Tums or Rolaids, and that might cause a problem. Signs and symptoms here: confusion, muscle tremors, cramps, bradypnea, and hypotension, right? So if they're metabolic alkalitic, it's going to be, again, it's hard to tell when they're in the field, right, without lab values. So how we're going to maintain pH as best as possible in the field is through capnography or capnometry, right? It's kind of become a standard of care. If anybody's having any sort of difficulty breathing, throw on your end tidal CO2 monitoring. Okay? And when you're looking at it, we're generally looking at something that looks like a plateau here and maybe a number. Okay? We want to maintain that number between 35 and 45. Okay? If it goes too low, they're breathing too fast. Let's try to slow them down a little bit. If it goes above 45, they're breathing too slow. Let's breathe a little bit faster for them to kind of maintain that 35 to 45 range. Okay? And if we're breathing normal, we should see a nice plateau like we're seeing right here on this picture. If it's something outside of the norm, you might see a different shape in this plateau. If it's kind of shark fin going up, so kind of a slow inhale, right? Or sorry, slow exhale, you might see a shark fin going to the top, right? That's generally due to some sort of bronchospasm on the exhalation phase. You might hear some wheezing or gurgling or something if you see that. If it's more shark finish or slow angled down this way, it's potentially a spasm or obstruction on the inhalation phase. So it's taking longer for them to inhale if it's going down in that way. So this is one way. This shows it on the LifePak 15. Pretty much all of the monitors that are currently available out there have end tidal monitoring on them. But there are other methods if you don't have a monitor to do. There is the pulse ox, like we have handheld pulse oxes. There's handheld CO2 monitors. And again, monitoring the CO2. The nice thing about monitoring end tidal, it usually monitors our respiration rate also, so that is helpful when we're slacking on the counting breaths. But so some of them will give you these two numbers. Some will also give you a waveform kind of look here. But hopefully you have something that gives you more of a nice value here, and we can print it out. Okay. Capnometry is that numerical display of the CO2 number. Capnography, the graphic display. Okay. So again, maintain it between 35 and 45, and we should be okay. If they get too low, breathe a little slower. If they get too high, breathe a little faster, and we can try to maintain it between them. Okay, so looking at the airway, after we've kind of determined their acid base, we want to look at that airway, right? Well, not really after, it's kind of simultaneously. So if they're adequately breathing, easy non-labor like we see right now, generally between 12 and 20 in an adult for breaths per minute, good depth, and a good regular pattern of inhalation and exhalation. Again, clear lung sounds. You're not hearing anything out of the norm. If it's inadequate, it's something different from what I just said. So they could be alert, talking to you. If they're in short, choppy sentences, that's inadequate, right? If they're talking to you, okay, it's not an immediate life threat, but maybe we need to help and get them some help down the road because they might get tired. Okay. Oxygen, right? We want to maintain our O2 levels between above 94 or per your protocols, right? So just if someone needs oxygen, give them oxygen, right? Don't withhold it if they need it. But generally we want to try to stay above 94. Yeah. Here's a good picture showing you accessory muscles being used. So this person is in obvious distress. Okay? He's using all of his accessory muscles between the ribs. We see that happening. The sternocleidomastoids up here. You can kind of tell it looks like he's pursing his lips a little bit and in that tripoding position. So this is a good picture of someone in respiratory distress, even though we can't see them breathing. So, but it's a good picture of accessory muscle usage. Things we want to look at if someone, when we're assessing that airway. How are they positioned? Are they in that tripoding position? Are they orthopnic, right? So if they sit up, they're okay, but as soon as they lay down, they feel like they can't breathe. We're getting good, adequate rise and fall of the chest. Are they gasping, pursing those lips? What's that skin color kind of looking like? Are they flaring their nares? Accessory muscles, all those fun things. Staccato speech patterns, right? Short, choppy sentences or just one or two syllables at a time. Depth, right? Are the skin looking pale, cool, moist? Regular rhythms. Okay? Those are all signs that this person is inadequately breathing. Okay? We might see things like Shane Stokes, which is your rapid and deep breathing that you probably are going to see with someone in a hyperglycemic event. Apnea, right? So they're just not breathing, or agonal gasps. So we see a gasp here and there. Again, none of these are really conducive to maintaining respiration in the system. Okay. So again, if they're breathing okay, but they're not, or they're ventilating okay, but they're not getting enough oxygen, they may be having issues there. Carbon monoxide, obviously that is 250 times more of a strong bond to the hemoglobin. So it's going to bind with that quicker, easier. We need to give them lots of oxygen. Your pulse ox might say 100% if it's a CO poisoning type of thing. Skin colors are good indicators. Pulse ox, usually pretty good. Capnography, really good indicator. Okay. When you're looking at the breathing. So once you've determined, hey, this is abnormal breathing, we need to open that airway. Okay. Many different ways to do it. You got head tilt chin lift if there's no C-spine issues, jaw thrust if there is a C-spine issue, right? Or if you're going to put in a supraglottic airway, you might do that tongue jaw lift maneuver where you take your thumb and finger, grab the tongue in the jaw and lift it up as we're shoving that supraglottic airway into the patient's airway. And then once we open it, then we have to maintain it. There's lots of ways to maintain it. If you don't have an airway, you're going to need to place them in a position that will maintain the airway. The number one cause of obstruction in a unresponsive patient is the tongue. So if they're not maintaining their airway or they're unresponsive, altered, the tongue might block their airway if they're on their back. So no airway, let's put them in the recovery position, whether or not that's the left or right lateral recumbent. Okay? Use gravity to your advantage and place them on their side so that the airway stays open. Otherwise, we've got oral and nasal airways. Oral airways, or J tubes as they oftentimes get called. All it is a plastic tube that is in their throat or in their mouth to hold the tongue out of the way. Okay. Can be used with BVM. Usually we do that right away with like a CPR patient, just to maintain that airway, but until we get a supraglottic in there. The problem with it, they can't have a gag reflex. So if the patient has a gag reflex, you got to do something else. So a patient has to be unresponsive for this one. Nasal pharyngeal airway can be used in a patient with a gag reflex. If they're unable to maintain their airway, they're not quite unresponsive, but they are in altered, or we're expecting them to be altered soon. They just had a seizure, so they might wake. You're expecting them to wake up on you soon, coming out of that postictal state, right? Again, this can be done with if there is a gag reflex intact and it's safe to do and usually doesn't cause people to start vomiting if it's in their throat. Be careful with trauma, especially if there's head trauma or facial trauma, and we don't want to place these into the nasal passage if there's a potential for skull fractures or anything like that. Yeah. Unconscious or breathing on their own, no respiratory distress, good reason for it. Contraindications, like we said, head trauma, facial trauma, exposed vein matter, or CSF draining from any of the holes in the mouth, whether or not they're man-made or new. Okay. So with the oral pharyngeal airway, it's pretty easy to measure. You go from the corner of the mouth to the angle of the jaw. Okay. That's how big we want to make sure it is to fit and hold the tongue out of the way. With the nasal pharyngeal airway, it's a little more complicated, but not really. Diameter should be the biggest one that fits into the patient's nose or their pinky finger. Lengthwise, tip of the nose to the tip of the earlobe or the tragus, either one. That's how long we want it to be. And let it go its natural curvature while you're measuring. Okay. If we need to suction, okay, we got to keep the airway clear, be able to ventilate the patient properly. So we might need to be suctioning while we're doing all these airways. Because you might need to remove fluid. And it is okay if any of these basic airways are in there that you suction alongside it or down the tube if needed. You can suction with those in place, and you may need to. You can also suction with your supraglottic airways in place, right? You can suction while inserting those. So make sure that you open that airway first with some suctioning, head tilt, chin lift. If you hear any fluid or anything, get that stuff out of there. Right? There's a few different types. You've got the one mounted to the ambulance. Right? You've got your handheld, hand-powered ones, or your portable battery pack ones that are also usually in the ambulance or vehicle. Right? There's lots of different type of suction catheters out there. There's a tonsil tip that fits down your supraglottic airways, or ET tubes if you're helping with those. There's curved tip contours, rigid ones that either the Yonker or the Decantu catheter, right? That'll help you suction out of the airway. There's soft, plastic, non-rigid ones. There's all sorts of suction catheters out there. Use the biggest one that you need and that fits in your patient's airway. Try to limit your suctioning, right? 15 seconds for an adult, 10 seconds for children, 5 seconds for infants. Right? You've probably been told 10 seconds in the past all the time, right? We limit to 10 seconds, that's great. If you have to go longer, it happens, but try to limit it. You can use gravity to your advantage too, right? If there's stuff pouring out, use gravity to your advantage. It'll pour out faster and you can suction it potentially. So maybe that left lateral comment, right lateral comment will help you too. As advanced EMTs, we can also do what's called tracheobronchial suctioning, right? If they are intubated, we can put that soft tube down into that ET tube and suction. Because if something's occluding the airway, we might need to suction. We can do that to our iGels, Kings, combi tubes, anything that's out there, you can suction those also. Okay. So here's just a short video kind of showing that tracheobronchial suction.
Prior to beginning tracheal suctioning, sterile gloves, a mask, and ice shield should be worn. Prepare as much equipment as possible, including having water available to clean the catheter between suctioning. Open the catheter package, connect it to a suction tube, and turn on the suctioning device. Insert the catheter until resistance is felt or you have reached your predetermined maximum depth. Carefully suction while removing the catheter. Limit suctioning to no more than 10 seconds. Insert the suction catheter into the prepared sterile water and clean the tip by applying short periods of suction. Following the same procedure, continue to suction until the airway is clear.
Okay, so you can just keep doing that until you clear out that airway, right? And try to breathe in between it if we can. But if there's something in the airway, obviously suction it out. Yeah. Oxygen, again, any patient that needs oxygen, give it to them, never withhold it if you think they're going to benefit from there. Oxygen does have a little help with reducing pain, maybe reducing further damage if there's like chest pain and stuff like that. Oxygen cylinders, there's lots of them out there. Generally, you're going to see like a D or E cylinder in your trucks. Those are your portable ones, generally maybe an M or an H that are mounted in the trucks. And then in the flight guys, they're probably using liquid oxygen, okay, as part of what they have in there. So there's lots of different versions out there. Make sure you have the right regulator for your patients, right? Flow meters, usually they're the ones permanently attached to the walls that look like this. Otherwise, there's other ones out there that are portable regulators that you'll probably see on your tanks in the ambulances. Other devices out there, we've got your non-rebreather mask, right? It's got a nice little one-way valve so that you're not rebreathing in. You fill this with oxygen. It's connected to oxygen. You want to make sure that you want to have it high enough that this reservoir stays inflated. Usually that takes between 12 and 15 liters per minute. Sometimes you can get away with 10 depending on what your patient is breathing like. Not necessarily the preferred device anymore, but if someone's breathing very, very hard, you might need to do this one. Nasal cannula, right? It's kind of become that standard care, what we're using if we're giving oxygen, because usually we don't need a ton of oxygen, but we're going to give it, make sure that we get your patient up above 94%. Oxygen delivery devices, there's other things like tracheostomies. So you could potentially just attach, you might have an attachment to attach to a trach to breathe for them. Your BVMs do attach there, but if they don't need a BVM, we just need to give them oxygen. You can put a face mask, non-rebreather right on there. Don't use a nasal cannula, but you can use a non-rebreather over that to help get some oxygen in there. You may see some oxygen humidifiers out there, especially in your long-term care facilities, maybe some of those transfers if you're doing some of those. But generally pre-hospital, we won't see that unless your patient is intubated and going to be that intubated for a while. So again, long-term care, if we have some sort of airway in there, this might be a good thing because we're bypassing the upper airway and that humidification process that they do there. So other things you might see it if you're somewhere treating a patient with croup or epiglottitis, bronchitis, something like that. If someone needs help breathing, right, we're going to use usually a BVM or potentially a CPAP, right? So that's called assisted ventilation. So BVM gives up to 100% oxygen. Give as much as you need as you squeeze it. Okay? We're only given enough to maintain chest rise. And it is, like it says, the most common used in the field. 2-person is best. There are automatic transport ventilators or other ventilators that you might see out there where the machine is controlling how the patient is breathing, right? CPAP, or continuous positive airway pressure, it's a non-invasive way of getting ventilatory support to our patient. And they do say that if you have early CPAP, you might prevent intubation down the road. So getting that on early with your patients that are having trouble breathing might prevent them from getting too tired to breathe later down the road. It's becoming very widely used in EMS. It is probably the most useful yet least used thing in the ambulance when it comes to somebody in difficulty breathing. Here is a version of it. There's multiple versions out there. Probably going to see the flow vent or the flow 2 type thing. But there's multiple versions out there. They're good for COPD, pulmonary edema, CHF, asthma. Those are the primary things that we're going to use it for. With your dry lung versions, we're going to probably go in a lower level of PEEP, right? So we'll kind of sit down at that 5 millimeters water. Whereas if we're in pulmonary edema, CHF, we got fluid on the lungs. It's take a little bit more pressure to get that fluid out of there. So we're going to go maybe towards the higher end there. Again, with everything airway, we're going to start low and titrate up until it's working. Things you got to remember, they have to be alert and talking to you and following commands. They might not be able to talk very well, but you have to be able to alert and to follow commands. Moderate to severe respiratory distress, they have to be breathing, right? At least generally they say over 26 a minute, but breathing fast. And then a pulse ox generally under 90%. Reasons you can't use it, obviously respiratory arrest, pneumothorax, trachs, GI bleeding, vomiting, unable to follow your commands, and you don't have a mask that fits your patient. Generally, patients ages 12 and up, maybe down to 8, depending on your protocols. if you can use CPAP. It's pretty easy to put on. It's going to cause some PEEP to help open those airways back up. Some patients might feel claustrophobic in it, so make sure you talk them through that as you're doing that. And it may lower your blood pressure too. So here's a version of CPAP, not necessarily the version that we have out in the field, but it is a version of CPAP out there. Okay, or not. But there is another video in the Blackboard that you can watch that in. Okay. Other things that you might see are your supraglottic airways. There's multiple versions out there. We've got the multi-lumen airway, like the combi tube here, where you have 2 lumens or 2 tubes going down into the throat. This one should be in the esophagus. It is blind insertion. So if you do it right into the esophagus, you'll be breathing through the blue tube as you're going through there. If you get it into the trachea, it has happened. You might have to go to tube number 2, which is the clear tube, while you're breathing for them. There are still some of these out there in the field. They're not completely gone, but they're kind of going away. Allows you to easily ventilate, easier than it is easy to do. Takes less time. You can throw it in there. It's a nice blind insertion device. Get an airway and breathe for your patient. Works great for CPR. Okay. King airway, very similar. Generally, it's just a single lumen airway though. So there's 1 tube going down to the airway. The new King LTSDs have a suction port tube on the back that you can run a suction tube down to the stomach if needed. Again, blind insertion. King has to go into the esophagus. Okay. Other things out there, you've got your LMAs, primarily used in ORs nowadays, but you might see other things like the iGel, which is becoming more and more common. Okay. These do also have to go into the esophagus, and they kind of block off that airway below and above and give you kind of a direct access to the trachea. So here's the iGel. This is kind of becoming that standard that we're going to use for our supraglottic airways because it's super simple. It does have some drawbacks. It does it does eventually become dislodged, so you got to make sure that you're securing that appropriately so that it doesn't dislodge on you. There's a video on this one in the Blackboard, so make sure you watch that also. Yeah. Lastly, foreign body airway obstructions, right? If we get some sort of obstruction, we can try to dislodge it, either suction it out, or you might need to do something like the Heimlich maneuver, abdominal thrust, or when they become unresponsive, we start doing chest compressions. Okay. The main difference there is when you're doing the chest compressions for a foreign body airway obstruction, make sure that you are checking in between for that obstruction to become dislodged. You might need to scoop it out. Okay. If there are any questions, make sure to send them to me in an email or in a discussion post in the course.